At this ESMO 2017 here in Madrid, I reported on the results of the Checkmate 238 trial on behalf of my co-investigators. This was a large phase 3 randomized trial of patients with resected high-risk melanoma, and when I say high risk, I mean patients who have stage 3B, 3C, and 4 resected melanoma rendered surgically free of disease, who have at least a 50% risk of relapse over 5 years and at least a 50% risk of death over 10 years. These patients were randomly allocated in a phase 3 adjuvant randomized double-blinded trial to receive treatment with either nivolumab, the PD-1 blocking antibody, at 3 milligrams per kilogram every 2 weeks for 1 year, or the active control arm of ipilimumab given at the US FDA-approved dose of 10 milligrams per kilogram every 3 weeks 4 times, followed by maintenance 4 doses at a 12-week interval. The results of this study, which was stopped at a planned interim analysis, which is always a good sign in a phase 3 study, the results were that there was a clear statistically and clinically significant improvement in relapse-free survival for patients who received nivolumab compared to those patients who received the active control of ipilimumab. The hazard ratio for the improvement in relapse-free survival was 0.65, which translates to a 35% reduction in the risk of relapse over time. The p-value for the difference in relapse-free survival was an impressive 0.0001. In addition to being more clinically effective, nivolumab was also clearly better tolerated and had less toxicity. By any parameter that you wish to measure, whether it be grade 3-4 toxicity related to treatment, or as a practicing oncologist, I count the proportion of patients who have to stop treatment because of side effects. By any parameter, superiority for nivolumab compared to ipilimumab. For example, fewer than 5% of patients receiving nivolumab had to discontinue because of side effects compared to more than 30% for ipilimumab. So the conclusion of our trial is there's clear benefit in terms of relapse-free survival, also in terms of distant metastasis-free survival, and superior tolerability and toxicity of nivolumab compared to the active control arm of ipilimumab. The implication is that we now have a new, hopefully will soon be a standard regimen of adjuvant therapy for patients with high-risk resected melanoma.